CDC-TV presents Health Matters.
Physically exhausted but mentally wide awake. It's what insomniacs experience nightly. And those sleepless nights can lead to a dangerous, potentially deadly problem.
911, what's your emergency?
Barbiturates were introduced into medical practice in 1903 after the development of barbital as a sedative hypnotic. By the early 1970s, barbiturate overdose was a leading cause of drug-induced death. These drugs are widely available. For this reason, most of the cases are drug abuse, suicidal, or ungraded exploration in children. It is potentially fatal form of poisoning with overall mortality of 7%.
The basic structure of all barbiturates is barbituric acid, which has no intrinsic CNS suppressant properties. The addition of an alkyl or aryl group confers sedative properties. Barbiturate compounds are divided into 4 categories based on their elimination half-lives. They can be classified as ultra-short-acting, short-acting, intermediate-acting, and long-acting barbiturates. They act via inhibitory gamma-aminobutyric acid or GABA synapses in the brain. They also suppress noradrenergic activity selectively. Barbiturates abolish central respiratory drive so that respiratory depression is the usual cause of death in patients without ventilation. Barbiturate abuse is still a major addiction problem in the population, although it has been partly replaced by addiction to other depressant drugs more commonly prescribed, such as benzodiazepines. Though most people who take these medications for seizure disorders or pain syndromes do not abuse them, many abusers start by abusing medication prescribed for them or for other family members. Others take them in suicidal attempts. The generally recommended hypnotic dose of phenobarbital, secobarbital, and pentobarbital for children is 2 to 3 mg per kilogram. Average toxic doses are 5 times the hypnotic dose, and severe toxicity may result from 10 times the hypnotic dose. Estimated lethal doses have been reported as phenobarbital 6 to 10 grams, secobarbital, pentobarbital, amobarbital, butabarbital 2 to 3 grams. An individual who reportedly ingested 20 grams of amobarbital did not survive.
Barbiturate poisoning is characterized by the depression of the central nervous system and the cardiovascular system. The onset of symptoms after ingestion depends on the type of barbiturate ingested. Victims of short-acting barbiturate overdoses develop symptoms within 15 to 30 minutes, and these effects peak in 2 to 4 hours. Long-acting barbiturates begin at 1 to 2 hours and peak at 6 to 8 hours. Neurologic effects of mild to moderate intoxication resemble ethanol inebriation with slurred speech, ataxia, lethargy, nystagmus, headache, paresthesias, vertigo, and confusion. Pupils are usually constricted but may dilate later. Corneal reflexes and conjugate Doll's eye movement are lost. Respiratory depression occurs early in coma, with slow or shallow respirations progressing to decreased vital capacity and minute ventilator volume. Hypoglycemia may contribute to CNS depression. Cardiovascular effects presents with a weak and rapid pulse, cyanosis, cold and clammy skin, decreased urine output, and hypovolemia manifested by tissue hyperperfusion. Depression of myocardial contractility causes hypoperfusion, and few dermatological effects were seen in 4 to 7% of barbiturate overdose cases. These include bullous skin lesions, primarily over pressure points. The toxidrome of barbiturate poisoning are depression of central nervous system and cardiovascular system. It includes ataxia, blurred vision, coma, confusion, delirium, deterioration of central nervous system functions, diplopia, dysesthesia, hallucinations, nystagmus, paresthesias, sedation, slurred speech, and stupor. Apnea is a potential complication.
Barbiturates in acid and salt form are readily soluble in methanol, thus is the solvent of choice in the extraction in qualitative analysis. Because barbiturates are acidic drugs, basic extraction cannot be done. One color test for barbiturates is the DELA test, which results in blue-violet color. The first solution is made up of carbol acetate, glacial acetic acid in methanol, and the second is isopropylamine in methanol. The second presumptive test is quick screen one-step rapid barbiturate test that utilizes the unique combination of monoclonal antibodies which selectively identifies barbiturates and are metabolized in urine with a high degree of sensitivity.
Minimum laboratory evaluation includes hematocrit, urine analysis, mainly for ketone bodies, WBC, and differential counts. Plasma concentration of electrolytes, blood urea, serum creatinine, and liver function tests should be obtained. Chest X-ray and blood gas analysis are mandatory.
A blood sample should be sent for measurement is of little value except to confirm the presence of barbiturates in plasma. Serial measurements provide a valuable guide to the adequacy of therapy.
The principle of management of barbiturate intoxication are like those many other drugs and are divided into three separate subsections: prevention of drug absorption, support of circulatory and respiratory function, and expedition of barbiturate excretion. Gastric lavage is done if no more than 2 to 4 hours have passed since ingestion of the barbiturate. Activated charcoal is an inert non-toxic adsorbent which binds high molecular weight compounds due to intermolecular attractions. 1 gram per kilogram is administered through nasogastric tube. Cathartic-like magnesium sulfate can be used along with it for further removal of barbiturates, but hypermagnesemia can occur. A clear airway is ensured by thorough suctioning and insertion of oral airway. In addition, the passage of barbiturates across the blood-brain barrier into the central nervous system may be facilitated during hypoventilation and respiratory acidosis. If the patient is comatose, prompt intubation is strongly advocated because of the fear of impending, worsening respiratory failure. Dehydration is corrected by central venous pressure, guided fluid therapy depending on the serum electrolyte reports. If hypotension persists, intravenous infusion of plasma volume expanders and vasopressors is started. In refractory cases, steroids are given. Frequent doses of activated charcoal adsorb the barbiturates when they re-enter the GIT through enterohepatic circulation. 1 gram per kilogram initial dose is followed by 0.5 gram per kilogram every 2 to 4 hours. Forced diuresis with alkalinization of urine is especially useful in long-acting barbiturates, which are largely excreted by the kidney. At high rates of urine flow, the renal clearance of barbiturates is increased. Thus, it shortens the duration of coma and decreases plasma concentration of barbiturates. This should be avoided in older patients as it can cause pulmonary edema, hyponatremia, and increased intracranial pressure. Hemodialysis and hemoperfusion are now being used extensively in treatment of barbiturate intoxication to increase rate of removal of barbiturates. Single 6-hour hemodialysis can remove an amount of barbiturate which is comparable to that removed during 24 hours of sustained diuresis or peritoneal dialysis. Analeptic drugs have minimal role nowadays because under their influence, true clinical assessment of patient becomes impossible. Also, they are associated with side effects like convulsion, cardiac arrhythmias, vomiting, and hyperpyrexia. The most important aspect of management in these cases is close observation and quality nursing care. Prophylactic antibiotics should be started. Good oral hygiene, temperature maintenance, and posture change at regular intervals. Usually, recovery from barbiturate coma is without neurologic deficit even after severe poisoning. The rarity of permanent damage after barbiturate coma precludes immediate establishment of adequate pulmonary ventilation as well as control of shock to be of prime importance.